but that was our focus. So we identified the concept as specifically as possible, brainstormed some indicators, defined it clearly, drafted some items, and then tried to balance the construct's actions and incorporate the breadth of the entire concept we were using. We were very aware at that time of not using complicated language, of what health literacy of patients would be, and really tried to incorporate an advocacy inquiry approach. You usually want to create more items than you need, even if some seem repetitive, and then you do a pre-test and a pilot test with it and redraft, refine, and retest. And as you may have noticed, we have been at this for 2 years now. There are some general guidelines around how many items. Usually you want at least 2 per factor or construct identified. Typically 4 to 12 items per factor are used, and the final decision really is subjective. It depends on your research context, looking at how it fits theoretically and whether it's measuring what you want it to measure. So this is how we developed the scale that we went on to test. We came up with 44 items, and as I mentioned previously, combined the methods we thought that were important in the actual action of developing a therapeutic relationship with the constructs we identified as being important: introducing oneself, being empathetic, building trust, educating while you were going, power sharing, which would include mutual goal setting, and developing rapport with the patient. And that to us was really a sense of our construct of therapeutic relationship. At that point, we were really fortunate. I shout out to my amazing colleagues in BC. We developed a team of about 16 to 20 content and clinical experts from varied disciplines in the province. It wasn't just nursing, but the majority, as you all can guess, were nurses, nursing faculty and nurse practitioners, and we varied it by institution, and we included both practice and academic colleagues. So the more robust your expert panel is, the better, and when you look at the instrument development literature and research, expert panels are a key component of it. So what we did was we had these 44 items. We developed the videos, which I'll detail in a minute, and we circled those 44 items to the expert panel and asked them item by item to review and tell us what method did they think that item represented from the list I just showed you, and what construct did it represent. So this was a way of kind of double checking how the inventors or creators of the scale had idealized each item with a group of experts. Did it all fit? Then that expert panel reviewed it in 2 rounds. They did that initial component, and that helped us to consolidate some of the scale. But the bigger piece was we developed these training videos and literally sat down together in a room, watched the video, used the scale, and then compared the answers to enhance that inter-rater reliability. During that phase, we tweaked a lot of the language. We looked at the descriptors very carefully and, went back and forth to land on what we did. So the training videos was really a unique idea. What we ended up doing was actually creating a script. And it was interactions between a public health nurse, who was a very experienced nursing faculty and a 20-year public health nurse veteran, and an older adult who was a trained actor and standardized patient. It was a home care video. This scenario actually is in the simulation textbook. And what we did was we tweaked the scripts to represent therapeutic, so your positive, good, nice interaction, non-therapeutic, and then mixed with a combination of both. And this way we thought we really would be able to test the scale. Was it picking up on therapeutic, non-therapeutic, and mixed interactions? And the only take-home message I want to share quickly with the group is do your non-therapeutic filming first. We saved it to last, and our nurse was so seasoned and so therapeutic in her communication, it was incredibly painful for her to be non-therapeutic. So it was hardest to film that one. Okay, so now back to the statistical component of it. Just a quick rundown on what is factor analysis, why do we use it, why is it important to instrument development. Those of you in the audience who have taken any courses like this or taken your statistics courses or those in graduate school know that this is a course in and of itself. I did an entire instrument development course to create my Campbell's breastfeeding self-efficacy scale. So factor analysis basically helps us to test the instrument we've developed. It helps to identify clusters where covariance exists, and that's our factors or constructs, and we do that with a multivariate correlational method. Basically, there are two purposes. One is theoretical. We want to be able to say that the items in the instrument overall is supporting theoretically what we hope to be measuring. And then the next is for data reduction. You'll notice we started with 44 items. Initially, we had about 80. And that is typical. You continue to decrease and reduce, so you're tweaking to get the best representing items. There are two main types and methods to extract and use factor analysis. One is exploratory and one is confirmatory, and we used a combination of both. So we again used a unique format for reliability and validity testing for this scale. Many of you may have noticed, and I have certainly noticed in the past 6 years, the participant burden for participation in online surveys. And we knew it was really critical that we got interested, capable people to sit and watch through this entire video. And you know, I'm saying 5 to 7, it honestly was more like 9 to 13 minutes. I think the poor communication was 9 and the really therapeutic communication video was 13 minutes. And some of you, thank you, I know you participated in the international version we did of this, and I think that there was high participant burden. Let me tell you about the crowdsourcers. They are with an organization called CSAPS in Seattle. Yes, you do hire them. There is somewhat of a fee, but they put up the entire survey, and these individuals are paid. Previously, this service has been used for surgeons. So surgeons will do a surgical procedure, be videotaped either live or in a sim lab or whatever, and these crowdsourcers observe that surgery and have a very specific clinical skills assessment tool by which they assess them. So what we were doing was asking them to complete the 44-item scale after watching these 3 videos. Our descriptors went from not applicable, which was a 0, to 1, never seeing the behavior, to 5, always seeing the behavior, or NA, that it wasn't applicable for what they were watching. As you can imagine, the higher score represented more effective communication, and when you are testing with that factor analysis, your best statistics are to recruit 6 participants minimum per item. 20 is the ideal. I always thought 10 was pretty good because the caveat is or an N of greater than 200. So you need 264 to 880 people. Any of you that have done survey research know how difficult and how much time that could take. For this crowdsourcing group, in under 2 weeks, we had, and I have it written, 700 or 800 responses. So that was the way to go for us. We did an exploratory factor analysis at that point in time and came up with one underlying single latent variable. The second order model worked best, and it had 3 sub-constructs of trust and rapport building, represented by 23 items on the scale, power sharing, represented by 9 items, and empathy by 9 items. When we looked carefully at the scale, We ended up excluding 2 of the items based on expert opinion. They did not load highly on factors. Our expert panel came back and we felt they were covered by other items. And also one, no matter how careful you are, we had the same question down twice. So that ended up with the 35-item scale that we then test. We have a depiction of it here, and what I want to share is, you know, underlying, I know it's kind of small, is that therapeutic relationship. That is the one factor model that we were able to demonstrate. So you can take an average of the score on this overall 35-item scale and come up with a measure of therapeutic relationship. You can also take item by item to provide students of the areas that they were doing well or not. The interclass correlation coefficient, so this was the other component where you want to be sure there's some inter-rater reliability. 10 of our experts, again, varied backgrounds and positions, did all 3 videos with the CSAT survey. And the team out there took the 10 expert panels, brought their scores together, and measured it against all of the other participants' scores. You're usually looking for interclass correlation coefficients of good to excellent, and that is how we determined how many items out of the 44 to keep. That's how we went down to our 35-item scale. And that ranged from good to excellent, all of those items. So again, that is pretty good to know. And underlying the Cronbach's alpha, which is a way to test the internal reliability of the scale, was 0.95, which again is very high. I know this is small and blurred. I'm showing it to you to give you an idea of how these are all the individual items. This is the scoring tool that people used. It was online survey. Again, I think that included some participant burden to it. When we allowed people to download the scale and have it in front of them, it was easier. You'll notice the analog scales at the bottom, and I'll talk about them in just a minute. I'm realizing I have about 6 minutes left. On the left, we were asking them from 0 frowning face to 10 smiley face, how non-therapeutic to therapeutic the communication was, or the relationship observed. And then the GITCS rating scale, we are asking them how hard to use with a frowny face to easy to use the scale was. So basically, the results for this confirmatory factor analysis were that a second-order factor model of general therapeutic relationship containing 3 sub-factors, empathy, trust and rapport, and power sharing, provided a good fit, and it provided a significantly better fit than a single factor model. And this provides all the specifics, and that's where I mentioned for you the Cronbach's alpha scale. So just to summarize, you know, we tested it. We used a web-based methodology, so people were completing the survey online. We developed those 3 professional videos that were randomly assigned to the crowdsourcing sample. And just to mention, we had 877 videos reviewed. So there's my number. We almost hit the 880 that would be recommended for 20 participants per question. Only 45 out of those 877 identified as healthcare providers. So the thrilling aspect of this, after it was all said and done, was we got a group of almost 850 patients to observe a nurse-patient interaction and use an assessment tool to measure that interaction. That definitely, the analysis represented the reliability and construct validity, and the interclass coefficient for the experts helped us keep the good to excellent items for the scale. So I wish I could tell you all, then you're done. My life has been instrument development, and it is an ongoing, continuous process. What we did is launched this in November to an international, interprofessional group, hit every Sim Center, nursing deans, 990 emails went out and asked people to do the same thing that the CSET folks had been asked. And many of you, I'm sure, participated in this for us, but the participant burden was so high. We launched it on a fluid survey platform, which was not very user-friendly, November to February. We launched again February to the end of April. In both cases, almost 100 people signed on, but less than 20 people actually completed the entire survey in the first round and only 30 in the second round. So we have barely 50 participants. We're still going to analyze the data and look at it. The first group of fluid survey gave us excellent feedback, one of which was, please let us download the scale. Can you shorten the videos? You know, they had great suggestions that we did. The other piece was we created a train the trainer model in BC, and as I mentioned at CASN and in Axel, please come see us. We'll be presenting on this, or poster and podium style, but that went beautifully, and it really helped us with the feasibility testing. So we had 8 schools of nursing sign on, 4 to 5 did live evaluation using that 35-item scale I showed you in the sim lab, observing, faculty observing the students and students observing themselves. So we will have manuscripts out on that data soon, and it was really exciting and fun to do. As part of the train the trainer component, we introduced it to faculty using synchronous webinar training. I created a 13-minute asynchronous video training, and I'm going to create another one for this final tool we've ended up with. And then we actually did on-site training, and as you can guess, the on-site training was best received. That's what faculty really wanted. So what do we do with testing from here? The construct validity is really important. We're going to analyze the overall scale measures with this analog scale where it was completed, and then Hammer et al. Have a really nice simplified scale. I'm not sure that there's a rubric for measurement associated with it, but it does differentiate therapeutic and non-therapeutic communication. So what you want to do is find a semi-similar instrument and then use your instrument and that instrument in a identical situation of evaluation and compare to see whether they are getting similar measures. The other aspect of future research that we're doing out here in BC is I'm hoping to create a website. Again, Julia, maybe you could cut and paste this website link in for everyone to grab. So surprise, the 35 item after feasibility testing this spring has become a 28 item categorized, reverse scored, ready to use instrument, and if you go to that website you can download and take a look at it. We're planning on the construct validity testing and then translating. This is in progress. We have a French version. I'm hoping there's a few Francophones on the line, and I'm hoping to connect with you all in Montreal next week. But a team at University of Montreal led by Patrick Lavoie and Jean-Christ Serviant in Belgium have both created a version, and we just need to consolidate them. A group in Colombia is translating it into Spanish. The Portuguese team is almost done. The Brazilian team that's translating to Portuguese. And I have partners in Korea and Hong Kong that are working on it. So the exciting part is we're looking to create research teams and make sure that the global aspect in the title is being served through. I have come up with a group of questions. I know that Leslie has been very carefully monitoring with Julia if there have been any questions in there, and I'm going to come back to them. I just wanted to leave up for about 30 seconds, so as people are watching the recording, they can take a gander at the reference list. Also, if you want to contact me, I'll give my contact information at the end. But as I hope you can tell, I am passionate about this. I love instrument development. I love finding ways to formatively assess and work with our students to improve their clinical and non-technical skill practice, which communication and therapeutic relationships certainly are. This Cardon and Egrin reference is in there, but the more up-to-date one, I think, I thought it was Anderson. There's been here. Okay. These you will be able to look at, and I'm happy to share them with you. And this was the HCAT validation tool that I was talking about in here with a lot of the research that's been done. There is my contact information that I will leave up. Leslie, I'm going to toss the ball to you to lead us in some questions and answers.
Okay, thank you so very much, Dr. Campbell, for such a great presentation. And we can certainly hear your passion in this presentation. I know for me, I was unfamiliar with that crowdsourcing. I think that's a very interesting concept.
Isn't it fun?
It certainly does, and the very fact that you could accomplish so much in little time. So that was really interesting. As well as it was very helpful to hear about the step-by-step process that you undertook to get this survey. Now, I don't see that we've had any questions from our participants so far, and that might be just because of where I'm positioned here. And certainly, Julie, if you have any questions for me, please send them my way. But I know that some of the questions that I would have around that would be, where do you predominantly use this tool? Dr. Campbell, do you use this more in your undergrad? Is it more do you use it in your master's, or do you use it in the hospital, the service sector?
So right now it has been tested in simulation labs with nursing students. My dream and hope and goal is that we will create an app version of it, maybe with even less than 28 items, that even clinical faculty could carry into the clinical site with them, do a quick on-the-spot review for students, provide them with feedback, and use it as a jumping-off component. The 4 schools where we live tested it, and I really want to thank my colleagues in BC because they welcomed me in with open arms. Faculty and students were incredibly responsive. What we noticed was we interjected them during the actual simulations that were already going on. And again, that was the intent with this. It wasn't meant to be burdensome and add-on. It was meant to be incorporated into what was already being evaluated for a simulation. And we just had students, right after their 20-minute interaction, take a few minutes, sit down, look at the instrument with a hard copy of it, and fill it in. And what we found was it really assisted with the debriefing. It got the students reflecting, not just many times they were complex scenarios and they were really focused on the clinical skills, and even when they had simulated patients, they weren't interacting, eye contact in general, and it just had them really thinking about, okay, wait, I need to take a step back. I know I'm feeling insecure about the clinical skills part, but there's a human being attached to this situation, and how do I interact and make sure they're comfortable? I'm sharing information with them. I'm gathering information to create a more mutual interaction. So the one up until now has been tested either assessing a web-based video that was scripted and professionally developed, or sorry, now I'm getting the little bounce up when people add in the chat section.
Yes, let me take care of that. And thank you for that, Dr. Campbell. There's another question here from Holdred Oderman. Her question is, have you considered using the instrument with students from other healthcare disciplines?
That is the goal. And that was the goal with the interprofessional testing of the instrument. We had folks not just from nursing, but for all the health professions. So I have medical students who have been working with some of the nursing students and asking for simulated experiences. We do have a few interprofessional scenarios that we do at UBC together, so I will be approaching those groups to see if we could use it there as well. But that's a great idea, and that was the intent of this, that it was meant for not just nursing.
Great, thank you. Another question here from Deb Whitmer. Have you recorded students and had students use this tool for self-assessment and reflection immediately after the simulation?
Yes. So at Langara, we actually used it with 3 different levels of students. And one of the situations, they were being videotaped, and then they reviewed their videos of the interaction, and I believe the faculty member was suggesting that they use the scale during that time to evaluate their communication and themselves. But that is a perfect use of it.
Okay, thank you. And here's another question from Monique Sedgwick. Have you considered using mask ed rather than professional actors?
Well, I'm wondering if Monique was at the NetNet conference, which was the first time I saw mask ed, and absolutely this could be used with any situation. And honestly, we use simulated patients, not standardized patients. Some of the medical nursing scenarios that are done once a year at UBC, they might be able to afford the standardized patients, but we use simulated, meaning that it might be a faculty member or a volunteer or clinical faculty or someone else acting the role of. And yes, I think that's a brilliant way to do it because you can really get at the interaction that way.
Okay, thank you. Now let me just, I believe there might be. Okay.
Great questions. Thank you so much. And
here's another question. I think it really has so much relevance, and I'm going to try and read it correctly here. Our faculty is reluctant to use any kind of assessment in simulation. A few of us, and so can you, and I'm sorry if I can't see the rest of that whole question. And so what do you do, Dr. Campbell, when there is such reluctance to use any kind of a measurement tool? How do you initiate that change, and how do you?
And that is such a wonderful question. For me, it was a little bit of culture shock because I came from an environment on the East Coast where we measured everything and we just didn't think about it, and we encouraged students to be part of it, and it was how we changed our programs and made our curriculum better. And I have noticed quite a bit of hesitancy, and my aha moment was I participated in the Gateway Debriefing Program as part of our Western Canadian Health Science Educators Conference last week on Vancouver Island, and was introduced to advocacy inquiry and reflection and good judgment, or debriefing with good judgment. And I have to say that I really think it's about psychological safety. That's why I added that 4th bullet that I have up on the questions there. Is there a sufficient level of psychological safety when using instruments or scales? So what we found with our team in BC was that those faculty who were comfortable with simulation, which again is a, newer and more challenging and outside the paradigm teaching method, those who were more comfortable there were more comfortable sitting with us and talking about this assessment scale. But what surprised me was I almost felt like faculty felt they were being judged on how well they would use this tool. So that's the other piece where I think we need to develop this level of psychological safety in our schools of nursing for faculty and students, that this is not punitive, this is not something that goes on a record as a bad thing, but using it more formatively. I think we're still away from the high stakes OSCE type testing where you pass, you fail, you get a grade. This is meant to be formative. and to help us all improve our practice. If and I might just pull up for a minute my beautiful framework, because I think the component of psychological safety fits in there, taking into consideration how learners learn, what their foundational knowledge is, how they integrate it, being caring about the way we are teaching, but that ultimately through simulation, we're hoping they will learn to communicate effectively, think critically, intervene therapeutically, and be safe, vigilant, excellent practitioners who are reflective of their practice and just always looking to be better. Sorry, that was long-winded.
No, I think that that's answered several questions. No, thank you very much for that. And I think that that really is the essence of simulation. That's what our goal is in really advancing the patient safety agenda. So thank you for expanding on that. Are there any other questions? I'll give our audience a few minutes just to type in any last-minute questions. And
so I do want to reinforce, related to that psychological safety, that the Train the Trainer really made a difference. So having capacity building with faculty, sitting down, using the scale together, whether on a video or a live simulation, talking about it afterwards, tweaking. And as you can imagine with any assessment tool, the more you use it, the easier it becomes. When we look at some of the preliminary data for the 8 sites in the province that use the instrument, we did a brief survey for faculty and students at the end, asking them how hard or easy it was to use, what would they recommend as far as changes. I think it was 8 out of 10 on ease of use of the instrument. So I think once people sat down, looked at it, used it, understood it, and I think we'll see a difference between that 35 item and the new 28 item version, they had a lot higher comfort level with it. So Train the Trainer and capacity building for professional development for faculty and use of instruments overall is necessary in my mind.
Yes, exactly, and I'm sure that all of us would concur with that. Now, I don't see that we have any further questions in our Q&A section. Any final thoughts, Dr. Campbell?
Well, and I'm looking at Colleen's comment to the group that the non-technical skill set, sometimes I think we do get so caught up in the trauma and ER type focus of simulation and think that that's all it's about. And I've been, teaching with simulation for 15 years now, and I really think my focus has been so much more in building the non-technical schools, helping students role play. Faculty can role play for students, but helping them practice different scenarios and ways of responding when unexpected things happen. And the simulated environment is a very safe place to do that. So I just want to thank the audience and Leslie, you and Julia in the background for managing the technology so beautifully. What a great way to bring us all together, and I'm hoping that there's interest in working together and collaborating.
Yes, thank you. Thank you so much, Dr. Campbell, for your time today and sharing your expertise with instrument development and sharing about the instruments that you have developed. Very, very helpful to the simulation interest group. And I would encourage those of you who are on the call that are not members to consider joining this very productive group. We share a lot nationally around what our current practices and what are some of our challenges. And so it's a really great way to network and collaborate nationally. And so I'd like to also thank Dr. Baker and CASN for the support of the Simulation Interest Group, and a very special thank you to Julia for making this all possible and for facilitating the administrative piece of this. So there will be a recording of today's presentation made available to those of you that would like to review it again, or if you'd like to share it with your networks. It will be posted to the CASN website probably within the next week. And again, thank you to you for joining us. And we hope to see you online or as well as at the CASN meeting next week. Thank you so much, everyone. Have a great day. Bye now.
Thanks, Leslie. Bye-bye. So, Julia, are you still there?